Good evening. Thanks for staying back. I just want to thank the organizers for giving me the opportunities. We'll change gears now. We'll talk about what happens to the older people when they... Can you hear me now? Yeah. We'll talk about what happens to older people when they sort of reach the last year of life. You know, I think it's very important that not many people talk about it, so we'll go through that. And also I'll talk about pain, the chronic pain, which is very important. Geriatrics and palliative care is a very sort of challenging topic to talk in 15 minutes, but I'll do my best. We have a lot of things in common. Geriatricians and palliative care physicians both sort of take a more holistic approach. We have a more comprehensive assessment, and we have more multidisciplinary team assessment. So let me define what is palliative care. Palliative care is a comprehensive care of advanced and terminally ill individual. We also treat the families, aim to improve the quality of care and promote adjustment to disease, and keeping in mind the patient needs, and we work towards a multidisciplinary team. Now, what are the principles of palliative care? It's a comprehensive and active approach to end-of-life care. Patient and the family are treated together as one unit. There is improvement in quality of life and promotion of dignity. That's very important, and it's an effective and efficient way to respond to patients and families' needs. Okay, I just identified 4 interfaces between geriatrician and a palliative care physician. This is what we do in Baptist. One is management of chronic pain. Number 2 is anticipatory care plan. Number 3 is making good, sensible, wise, ethical decisions. Number 4 is end of life. So let me start with defining what is pain. Okay, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And the simple definition is whatever patient says hurts is pain. What are the different scales that we use? We have a visual analog scale, there is numerical rating scale, and there's a category rating scale. There's a totally different set of scales for patients with cognitive impairment. Okay, there are different dimensions of pain. Melzack and Wall outlined 5 dimensions for pain. One is a sensory dimension of pain, what you actually experience. There is affective dimension, that is the emotion bit of pain. There is a cognitive dimension to pain. There's memory of pain. People who have experienced pain will react more than the actual pain because of memory of pain. And there is autonomic response to pain. You can hear me now? Yeah? Okay. More than 50% of older people suffer with chronic pain. Chronic pain is a pain which is present for more than 6 weeks. There are less obvious physical signs. Acute pain is pain less than 6 weeks. More often there are physical signs. Now, this is a study published in 2001. They found that patients who experience chronic pain are more forgetful, they are prone for minor accidents, the difficulty in concentrating, problems with attention. At least more than half of them reported at least one difficulty when they're having pain. So managing pain is very, very important. Now, normally we use WHO pain ladder, which is quite simple and straightforward. So what do you do when you have a mild pain? We start with paracetamol, which is a very good drug. We start with a good full dose, 1 gram 4 times a day, which is not advocated here, which I started using very much in Baptist Hospital. And if you can't control pain with 1 gram paracetamol, then you go to ibuprofen with making sure that they don't have any problems with liver or any GI toxicity or GI bleed in the past. And I tend to use naproxen, which is quite good drug with paracetamol. It gives good effect. Aspirin in high doses can also give you good amount of analgesia. If the pain is not controlled, then we go to mild opioids, what they call it as. We can use codeine, which is available as an individual drug, but in some countries you have a combination of codeine and tramadol, paracetamol. Tramadol is also available, and dextropropoxifen is another one. You got to bear in mind that it can constipate, and you got to be very careful when you're using it in a patient who's known to have IV drug abuse in the past. Now, when you have severe pain, that's when I call upon my palliative care consultants to help me out. Normally we manage together. We can use, apart from the non-opioids, we can use morphine in an oral form, in an IV form, in an intramuscular form. oxycodone, oxynorm, hydromorphine, the fentanyl patch, and also buprenorphine patch. You got to always bear in mind the side effects are constipation, sedation, increased risk of falls. You need to weigh the risk and benefits, and beware not to use in opioid naive patients. So you need to always start with milder opioid drugs. Now, I'll briefly touch upon this two special pain syndrome, that is neuropathic pain. Neuropathic pain is a pain that originates from the nerves. There are different types of neuropathic pain. You have pain after a herpes infection, it's called post-herpetic neuropathic pain. You can have a cancer neuropathic pain, which is very complex to manage. You have a neuropathic pain very often seen with diabetic patients, it's called diabetic neuropathy. You have neuropathic pain post-trigeminal neuralgia. You can have neuropathic pain with HIV infections. Normally we use non-opioids, that is paracetamol and with opioids. And also we use what is called as pain modulating drugs like amitriptyline, gabapentin, anticonvulsants like topiramate and other drugs, and ketamine as well. There are two regional syndromes called complex regional pain syndromes, type 1 and type 2. Type 1 is because of tissue injury. The treatment is sympathectomy. In type 2, it's more often because of cancer infiltrating the neural plexus. Now, this is very important. Incident pain is quite common. I'm sure my oncology colleague will agree that patients, although they're well controlled with pain, they do have incident pain. What is incident pain? When a terminally ill patient, when he turns, he'll have a lot of pain because he has metastasis to the bone, or he has oral mucosal lesion, he's not able to swallow. What is advised is that you keep a good control of analgesia. On the top of that, you can use medicines which act very quickly. You can use local clonazepam, amitriptyline, ketamine, and you also have morphine, rinse mouthwashes are available as well. And for local bony pains, you can radiation and bisphosphonates are quite well used. Radioisotopes are not very good. Oral transmucosal fentanyl is available. That's quite effective. It's not available in this part of the world, but that's quite effective as well. But if you still have a severe incidental pain, sometimes we use patient-controlled analgesia as well. Now, what are adjuvant treatment that we use? Antidepressants, what's called as SNRIs. There's duloxetine and venlafaxine. The anti-epileptic that I just alluded to you, which can be used. Topical treatment like capacin and lidocaine patches can be used. Pain is a biopsychosocial response. So, cognitive behavior therapy has its own place in treatment of pain. Now, these are interventions. I won't go into detail. Epidural injections are used for patients with spinal cord stenosis. And sympathetic nerve blocks are used for patients with complex regional pain syndromes, and peripheral intra-articular injections are used for patients with osteoarthritis. Now, we'll come to tricky bits now. This is what is called as anticipatory care plan. It is a well-established practice in the West that if somebody is going downhill, it's always you need to take patient into confidence and the relatives into confidence.
Dr. Dominic, you have 2 minutes more.
Okay, I think we'll skip. In patients with cancer, there are exacerbations where there's a decline in the function and they go down quite quickly. But in patients with frailty and dementia, they have a low reserve and they go down in the gradual decline as well. So what is anticipatory care plan? It's basically drawing up a care plan, speaking to the family, and finding out what are the patient's goals and needs. What does he want? Does he want to die in ICU? Does he want to die at home? What does he want to do? What he wants to? How does he want to spend his last year in life? It also equips the family to handle psychological and existential demands of advanced cancer, and it also gives you a guidepost for future care when an individual cannot make any further decisions. So it doesn't put the family into guilt. What are the essential elements? We need to identify patients who may not be alive for in the next 1 year. The prognosis is bad. We need to have a chat with them in terms of informing them what could be their disease trajectory and how can we manage. Now, most important is we should elicit what is patient's goals, his needs and worries, so that we could sort of alter the care plan according to him. What are the common errors? Many consultants don't want to have a frank discussion about the prognosis. They have a problem with patient's autonomy. They feel that if they respect patient autonomy, the professional judgment won't be sort of valid. And I think we need to ask, what do you think the loud one would want to be done, rather than asking them what you want to be done. So next, coming to the ethical bits of it. Now we normally face, especially I see patients who are advanced dementia coming into the hospital, or terminal cancer coming into the hospital. These sort of questions come up. When do you stop transfusing in a patient who's anemic in a terminal cancer? When do you beg bad news, and how much do you tell the patient? And when do you withdraw artificial feeding for somebody who's on artificial feeding as a terminal disease? And how do you manage? This is very important. This is a tricky bit. How do you manage clash of opinions among relatives in a terminal patient? And suppose the terminal patient becomes unwell at home. What do? You tell him to come to a hospital or die at home? And when would you withdraw essential treatment? These are tricky ethical questions. There are two types of wisdom. One is theoretical and practical wisdom. I think you need to have practical wisdom to make such decisions. And normally I use this sort of classification to navigate through. I'll just briefly sort of mention that type 1 is find out what the attitudes are. Attitudes are normally shaped by education, culture, and religious beliefs. And the second bit is, how do you handle difficult decision making? Who's the decision making person? Is it next of kin? Is it an uncle? Or who's the other one? And third thing is, do you have the capacity in the hospital to manage such patients? Now, the bioethical principles what we follow is what is well accepted is do no harm to the patient, non-maleficence, respect patient's autonomy, and always do best for the patient, and try do the equity of patients. So involve a multidisciplinary team so that you don't play God, and you go by what's accepted ethical principles. Now I'll just skip the slides as we are saying. What's end of life? I just make a thing. It's very important that you live your life with dignity, and also you die with dignity. I think that is the most important thing. If you want to take home from this talk, is that and diagnosis of dying is very important for optimal management of end of life. And altered state of sensorium can be a sort of prelude before the ultimate thing happens. Normally the doctors are hopefully they're sort of well versed in sort of diagnosing the imminent death, that is means mottling of skin and chain stroke breathing. But there is something called transient phase of dying, which happens weeks and months before this patient goes downhill. So if you can pick it up, you can give a time for the family to make plans and sort of talk to them and find out what the fears are. If somebody is sleeping more weakness, profound weakness, decreased interest in the surroundings, loss of appetite, confusion, falls, and incontinence, all the symptoms together. You can have individual symptoms in different contexts, but if you have all the symptoms together, that sort of patient has gone into a transient phase of dying. Probably this patient is going to die in a couple of weeks' time or a month's time. Now, what are the 5 domains of good end of care life? It's adequate analgesia, avoid inappropriate prolongation of dying, achieve a sense of control for the patient and for the relatives as well, relieve the burden on the patient and the relatives, and strengthening relationship with the loved ones. It's very important that you tell the patients what's your projected lifespan would be, so that you could sort of mend fences with friends whom you need to mend fences with. You need to meet friends whom you need to meet friends, or you need to visit a place or something like that, which is very, very important for the family as well. Now let me sort of end with a quote: "Laugh so hard that even sorrow smiles at you, and fight so strong that even fate accepts defeat, and love so true that even hatred walks out of the way, and live life so well that death loves to see you exist." Thank you.
Thank you, Dominic. I think you left us very emotional. I think this is a very hard phase of life to really see it practically happening, but I think we could face it out the way you put it across in the detail of presentation. Thank you very much for that lovely presentation.
We'd like to thank Dr. Benjamin once again. Let's give him a round of applause. Thank you.